Good afternoon. My name is Shannon Legere, and I'm from PATH, People Assisting the Homeless. Joel Roberts was supposed to be here. He's our CEO, but he's on vacation in Asia, so you get me. So I'm going to talk to you about housing and healthcare strategies, and really none of this is rocket science. I think most providers in the room are probably doing this, and this is what we see as effective today. We're continually self-reflective to figure out, okay, if it's not working, if we're not getting enough people off the streets, if people aren't retaining their housing, what else can we do? So our thoughts on this continually evolve. So this is a reflection of today. Just to tell you a little bit about PATH, we started in 1984, and in the beginning, the motto was a hand up, not a handout, and we were really serving episodic homeless folks, and these were people who were down on their luck, lost their job, maybe they couldn't live with friends and family anymore. They moved into our shelter where we provided a safe, warm, nurturing environment. They were able to get back into the workforce and return to the community. So these are people that we didn't see cycling in and out, and they were really just episodic. Fast forward to 30 years later, we are serving a completely different population. We are serving the most vulnerable, the most complex case management, chronic health conditions, psychiatric conditions, substance use issues, and these are the people that are the hardest to engage as well. At PATH, we really focused our services on serving veterans, individuals, and families, and that's pretty broad, but this is where we're seeing vulnerable populations. We provide services across communities in Southern California, and the range of services is from street outreach to field-based supportive services, housing location, employment. We have interim housing. And then in 2007, we started developing permanent supportive housing, and we started PATH Ventures, which is another division of PATH that builds housing. And during this time, we also began to shift our programming in our interim housing and our street outreach to really match the population we were serving. We needed to evolve. We needed to use evidence-based practices. We needed to target the most vulnerable. We needed to try anything that was innovative to get these folks off the streets in the communities and stabilized in housing. So we've really evolved in the last 7 years, but from 1984 to now, we're completely different. So some of the strategies that we use to get people in housing and to stabilize folks in housing include what I call an integrated approach. I know integrated is used in the medical field and used in all different ways, but for us, it's really an approach of, it's rooted in case management. We deliver directly a level of substance use counseling, mental health counseling. We coordinate with providers that do the same or more intensively, and we also coordinate with healthcare providers. PATH does not have medical staff, so we are dependent on community medical providers or on-site medical providers for that. We also have really embraced evidence-based practices. The ones that we're primarily using, housing first. We're moving people directly from the streets, from street outreach, into permanent housing. We use critical time intervention as a strategy, which is like the best practices of case management to help people stabilize once they get into housing over a short period of time. We're also using motivational interviewing and harm reduction, and these are all interwoven together. It's not a one-size-fits-all approach. It's really based on the individual and their needs. We also really think that choice and empowerment is huge for this population. So as often as we can provide options of housing, options of services that the person can engage in, options of treatment providers, we do so that our folks feel like they can make choices and they're empowered to do that. We're also recovery oriented. We need to help these folks build a life outside of their disability or their homeless status. Many people come to us and think, I'm a person with schizophrenia and I'm a diabetic and I'm homeless and that's all I am. And so we focus on employment and how to be a good neighbor and how to be a friend and how to reconnect with family and just all of those things, hobbies, education, all those things that make all of us who we are beyond our chronic health conditions and our homeless status. We're also heavily focused on skill building. We don't want to be in this role forever. We want to teach people or help them relearn how to live independently, how to manage their money, how to deal with their crises when they come up, whether it be health or psychiatric or just interpersonal relationships. This is really important work, and this is the core of the case management. For our healthcare relations, PATH really takes a whatever it takes approach. So we have a little bit of everything going on. So we do field-based scattered site housing where we partner with the VA and DHS, and we either take our clients to those medical facilities or we coordinate with them to have their medical providers come out to our clients. So we do that as needed, and it's really based on the individual. In San Diego, we rehabbed a facility where we have 150 interim housing beds, 73 PSH units, and on the bottom floor is services and FQHC. So for all those people living in the building, the FQHC is their medical home, and they get their whole range of treatment. We also have 16 beds that are preference for folks with HIV. They also get their treatment on site in the facility. The Kretz model is, a little bit of a community collaboration. We have an FQHC around the block. We bring providers in. We do a lot of health education as staff for our clients. But that's probably more typical to what most people experience if they're living scattered site in the community. As we move forward and we're building more PSH developments, we've started to carve out actual space for health providers to come in on site and be permanent fixtures there. We think that's really important. We think that's easy for our folks to access. If they can go and take the bus and get to their medical appointment, that's great. But for those that can't, we want that ease of access. So we're starting to do that in a more standard way. This is Kretz Villas. I was laughing because I forget which gentleman was saying that it was from San Francisco that you have the Windsor and all these fancy names. At PATH, everything is a villa. So this is Kretz Villas. So this is a building we opened 2 years ago. It's developed by PATH Ventures. And this was our first pure PSH development. So we did Silver Lake Registry, the Vulnerability Index, and we housed everybody from that Vulnerability Index in this building. We have 8 units of the 48 that were dedicated to folks living with HIV or AIDS. We have on-site supportive services. We bring a lot of providers off-site to come on-site and do a lot of training for our clients, health education, and for our staff. And we're really trying to create this community of the least restrictive environment. You can live here, you can access all the services you need. Even when your health is deteriorating and you're not doing so well, we don't want you just to automatically have to go to the hospital. How can we mitigate some of this stuff? So we really try to create a culture where you can access everything on site. So some of our lessons learned. I really think a healthy organization is self-reflective, like I talked about in the beginning. So these are my lessons learned from last week. Some of these might stick for next week, and I might have some new ones, but here's what I have. So when we're serving this population, building the health literacy of our staff is hugely important. At PATH, we have case managers with a range of lived experience, professional experience, different educational backgrounds, and they make up this very rich, diverse team, which is great, but our understanding of diabetes and HIV and STDs is really uneven. So we've spent a lot of time bringing in training for our staff so that we can raise their literacy level on health issues that they're dealing with day in and day out with our clients. Staff support and resiliency. So and I'm kind of a little bit on a morbid death theme here, so sorry. We've had some deaths, and this work is so emotionally taxing. And as an employer, we're really trying to figure out how do we support our staff in getting through this. Many of our folks, We are their sole relationship. They don't have natural supports. They're not connected to their family. They're barely connected to their neighbors, even though we're working on it, that we are that main relationship to them. That's really taxing on the staff when you've had, multiple deaths or multiple people just deteriorate and are in and out of the hospital. So we do things like, we have EAP, we encourage staff to go there. We do debriefing as a team. We also provide one-on-one support. And then we kind of just take it on a case-by-case basis. We're still figuring out what to do in this area, but we recognize that we need to do more as an employer. Also, we've learned that and this kind of ties into what I was saying, the importance of natural and social supports. It's not healthy if we're the only ones that our folks that we're serving are connected to. It's healthy and healing for them to have a support system, especially in times of crises or even in times of joy and celebration. And so we're working really hard on creating that. There's some tools that we've been using to deal with all of this: 5 wishes, wellness recovery action planning, and advanced directives. And these are a mix of, pre-healthcare planning in times when you're doing well as RAP, if you're not familiar with that, comes out of the mental health world. And really in times of distress, psychiatric crisis, what are the things you can do as a client before you reach out to your paid professional or before you go into the hospital? And I kind of think we all need a RAP plan at some point, I think it's really healthy for us to know when I'm stressed out, I need to go for a walk, or I need to take a bath. And so that's the kind of tools that interventions you're developing with clients in RAP planning. The other lesson that this one I think is going to always be on my list is role clarity and confidentiality with permanent supportive housing. So in PSH development, you have clients, you have property management, and you have services. So, everybody knows that the clients have stuff going on. Property management, we're always working with them on, okay, let's look at the behavior that's jeopardizing tenancy. Let's not talk about if they're taking their meds or not, or if they're psychotic or not, or whatever the issue is. And so we're always having to re-clarify that role. Also, our property management, they're humans too, so they connect with our clients. They smoke cigarettes outside, they talk, they take walks, so they have relationships with them too and hear a lot about our clients' lives. So when they go to when clients go to them for help, we're always having to coach them about redirect them back to services. We got a plan we're working on. And so this is an ongoing relationship thing with property management as a PSH provider. The last thing is, if you're connected to us on Facebook, we regularly post our welcome, I Made It Home, our Welcome Home campaign. And this guy in particular I think is cool because he's got a hobby, and it's music. And you can see the speaker, and you can see the drums and the guitar, and his neighbors don't love all that. But, this is cool. This is what we do. And this just reminds me that housing is healing, and housing is about improving the quality of life, and that's what we do. Thank you.